A very good afternoon to you, ladies and gentlemen. Special welcome to the members of the media who have come out to join us. And welcome to those of you at home and wherever you are, home and abroad, listening to our regular update on our management of our COVID challenge. This afternoon I have the usual team with me, and I would like immediately to ask CMO to take the mic and give us our update on our situation here in Trinidad and Tobago.
Good afternoon, Honorable Prime Minister, Honorable Ministers, colleagues, members of the media, members of the viewing and listening public. So we begin as is usual with the COVID-19 update for 21st of May 2021. Both public and private facilities testing 163,616. Total new positives over the last 24 hours 708. From 12th of March taking us to 18,935. Total patients recovered 11,099. Total active cases at this point 7,488. 348 deaths in all, and patients in hospital stand at 407. Dr. Richards will go into detail with regards to that statistic. Total patients in step down 163, and those in quarantine facilities 328. The restart of the vaccination process takes our total persons vaccinated with one dose up to 62,360 and fully vaccinated to 1,179. Sorry. So I just have a few slides comparing the COVID-19 spikes in Trinidad and Tobago, September 2020 versus May 2021. So looking at some pertinent data, we were looking at the hospitalization rates, for example, and certain trends popped out at us. So this first graph shows the number of people with comorbidities and without comorbidities that would have been admitted to hospital. Starting on the left, look at September. We see that those with comorbidities, about 36%, those without, 64%. In May, conversely, we see a flip of that arrangement, where those without comorbidities, 61.4%, and those with comorbidities, 38.6%. What happens in those instances is that you find that the ones without comorbidities usually have shorter hospital stays, they usually have better prognosis. Those with comorbidities have been having, of course, longer stays and worse prognosis in the long term. Again, looking at comorbidities, break down different types. More or less in terms of diabetes and hypertension, September and May are almost the same. What we see as a slight difference is the number of asthma, 12.6 in May, 9.8 in September. More or less, we're seeing the same sorts of comorbidities, and what again stands out, chronic kidney disease seems to be a little higher in May, 9.4%, as opposed to 1.6% before. Again, male to female ratio had stayed more or less the same for the entire period, 50-50. Those with symptomatic versus asymptomatic. So look at the left again, September. We're seeing persons who are symptomatic accounting for 35.7%, 64.3% asymptomatic, and we're seeing an increase in May of the number of people who actually have symptoms at home. So 50.5% of those persons at home, which is more or less half and half, have symptoms, and the ones asymptomatic, 49.5%. Percent of active cases hospitalized, we're seeing an increase in the number of people who actually have COVID and need hospitalization. So between September, 5.3%. In May, we're now seeing that at 8.0%, which will translate to a greater need for hospital care. Average daily number of patients in hospital in May, 316, September, 98. And just to sum it up, so in May, it was noted that more people without comorbidities are requiring hospitalization, in contrast to September, where the majority had pre-existing medical conditions. The gender distribution remained equal throughout the epidemic. 1/2 of persons in home isolation have symptoms in May, while 1/3 of those people had symptoms in September. And there has been not only an increase in the number of patients requiring hospitals, but also an increase in the percentage of active cases overall. I think we'll go into Dr. Hines' presentation followed by Dr. Richards, and then Dr. Trotman.
Thank you, CMO, Honorable Prime Minister, Honorable Ministers, colleagues, members of the media, members of the viewing and listening public. I will be reasonably brief in giving the epidemiologic update as at yesterday. Having already seen the data with respect to the numbers of new cases, etc., we'll dive directly into the epidemic curve. And here we're looking at the relationship between the restrictions that we would have gradually, incrementally implemented and the pattern of occurrence of cases. And the epicurve is, as it has been before, the gray, now short-looking bars being 2020, and the increasing in height from left to right as we move through the colored bars from January through to the current gold bars in May. We're seeing that upward trend in numbers of cases daily that has been going on since about March. And we do note that the closure of restaurants, bars, worship gatherings, mall, retail, non-essential public service, the biggest of the current restrictions. When we started doing the restrictions, we started with the small things and then made the big jump to closing many things at the same time. That occurred on the 29th of April, and we are seeing 2 weeks after that we're noting a peak in cases around the 11th, 12th, 13th of May, which may or may not be associated with that last-minute rush that we do note when something is closing or being threatened to be closed. There is a tendency to gather, but if you're doing that in a situation where virus is more prevalent, then that can spawn more cases, and it may be responsible for the heights of the bars around that time. The bars towards the right-hand end, which are currently shorter, we're still making sure that all the information has come out of the system relating to cases swabbed on those days, but they do seem to be a little shorter. We're hoping that as the rest of the data comes in, we begin to see something of a downward trend, but we can't say that we're seeing that just yet. The weekly positivity stands at about 47% just for this week 20, the week that we're currently completing. And we see that that positivity, that salmon area has continued to increase basically from mid-February all the way up. That positivity, again, reflecting the number of positive cases we get out of every 100 swabs that we take. Now, this doesn't mean that 45% of the population has COVID. The swabs that we take from high probability or high yield cases, which are cases who are symptomatic, or cases who are in contact with ill people. And out of that sampling group, what we've been seeing is this 45, 46, 47% positivity at this point in time. Looking at the monthly tallies, we see that May far and away has the largest tally so far, and May is nowhere near finished. We're already at 8,111 cases for the month of May. Average positivity for the month of May being about 43%. The gender distribution is largely, as the CMO has also indicated, approximately 50-50 male-female, and still the largest grouping being that 25 to 49-year-old age group. We do note that among the fatalities, we see there's a little bit of a swing towards more females and slightly younger people that we're noticing in this, this new surge. So whereas previously we saw 75% men, we're now seeing only about 62% men and 38% women among the fatalities. And whereas the 60 to 69 was above or just around 70%, and the under 60 was 30% or less, that has increased to about 35, 36% at this point in time. Geographically, we're going to compare 2 weeks. The yellow dots here and the yellow bars representing week 18. So you see the distribution is across all community centers, let's say community centers, population centers in all communities. And for week 19, new yellow dots, so the ones that we saw here are now turned purple, and a new set take the place. See that the number of dots is still very similar. Still large numbers of cases across all the population centers. And when we sum that up by community, we get this sort of distribution, bearing in mind that the clustering in the Chaguaramas area actually has to do with a cluster that was mapped to a particular facility in the area, as opposed to being in the community in that area per se. The current and projected cases, as we've been showing, we made a projection using the data from the last 2 weeks of April, and that was the green curve that is going upwards there. We are beginning to see that at the approximately 2 weeks after that April 29th time frame, we're starting to see where those bars are falling away from that green projection very slowly, but hopefully that is a trend that can be optimized and maximized as the measures and the effects of those measures take hold. Looking at the current versus projected new cases and active cases, the new cases being those orange bars seen at the bottom of the graph, and the projected new cases, the ones that we thought may have happened if the epidemic continued along its projected trend at the start of May. Those green bars are taller than the actual cases, meaning we didn't have as many as projected, which is a good thing, but we still have a great number with respect to all of our internal capacities, and this is why we still need to ensure that we reduce the number of new cases by adhering to the measures so that we don't overwhelm those capacities, which Dr. Richards will speak about. And with respect to the active cases overall, whereas the yellow dots showed where the active cases were projected to go, we are now seeing that there is a slight trend towards fewer of those active cases, but we're not out of the woods. So we want to ensure that the behaviors that we continue to engage in reduce the accumulation of active cases so that we can reduce the strain on the public health system. And I believe there I will turn it over to Dr. Richards.
Good afternoon to the Honorable Prime Minister, the Honorable Ministers of Health, National Security, Energy, and the Office of the Prime Minister. Good afternoon to members of the media. Thank you once again for your continued participation in our press conferences, and to the listening and viewing population of Trinidad and Tobago. This afternoon, I would like to provide an update on the clinical statistics for the parallel healthcare system, especially as they are related to the hospitals in this system. As you can see from this graph, there has been an increasing number of new cases, a general upward trend, and the gap between the number of admissions and discharges has been closing over the last 4 to 5 days. If the last graph was expanded, you would notice that there has been a narrowing or an actual closing of the gap between admissions and discharges at the hospitals in the parallel healthcare system. This narrowing can be, or this closure can be attributed to 2 factors that are ongoing. Firstly, there is an improvement in the operational and allocative efficiency of the system. Over the last 24 hours, we added an additional 92 beds through the new Point Fortin Hospital, where there are 60 beds, an additional 32 beds at the Cooverfield Hospital. Furthermore, we have been reallocating human resources, that are doctors and nurses, into the demand areas. For example, we have additionally converted about 30 ward beds into 11 additional ICU beds. We have also improved the clinical efficiency, so we are looking at the accurate admission and discharge of persons. The 7-day rolling average, as indicated by Dr. Hines, continues to increase. We're currently at 508 as of today. And the daily admissions, we actually saw a decline in that trend recently, or within the past week. This graph demonstrates the total hospital occupancy between Trinidad, Tobago, and an overall occupancy. And as of this morning, the overall hospital occupancy is at 70%. If we disaggregate or separate these occupancies, Trinidad is at 76% and Tobago is at 31%. We are also looking and charting the ward occupancy levels, because different persons with COVID-19 require different levels of care. And of course, that determines how we allocate the relevant resources across the parallel healthcare system. You would see a red horizontal line, and a 75% occupancy is considered to be worrisome or one of concern. You would note that the overall occupancy and ward occupancy continues to trend upwards, and this morning it is at 74%. Now, the ward occupancy in Trinidad, if we separated Trinidad from Tobago, is actually at 81%, and in Tobago it's approximately 30%. You would also notice that the ICU occupancy has decreased, as well as the HD or high dependency unit occupancy has decreased. And we have in fact added ICU beds based on the demand for care. I would like to remind members of the population that resources are not unlimited. They will be used up at some point in time in the near future, and we are testing the resilience of the parallel healthcare system if we continue on the trends that we are. Lastly, I'd like to just summarize the hospital occupancy levels. Again, different hospitals are required for different levels of care. The Cora Hospital is currently at 93% occupancy. The Couva Medical and Multi-Training Facility, which cares for our most ill COVID-19 patients who require, the largest numbers of nurses, doctors, and personal protective equipment, ventilators, is at 71%. The Arima General Hospital, at this point in time, 99%, despite a phased increase in the number of beds. The Augustus Long Hospital, 81%. St. Anne's, 100%. The New Point Fortin Hospital this morning was at 73%, but as of 2 p.m., it is almost at maximum levels. And this demonstrates that although we continue to add beds and we continue to reallocate limited resources by moving and rationalizing doctors, nurses, and equipment, the beds continue to be filled. The area hospital, Point Fortin, one of the new step-down facilities that was activated last week, is currently at 85%. And the Port of Spain Field Hospital, activated on Wednesday afternoon, is filled at 100%. The day-based step-down facility is at 72%. And the UTT Valsain facility, which is another step-down facility, is currently at 55%. But we have to note that even though there are physical beds that are left at this facility, staff has been reallocated into new hospitals in that region. This demonstrates what I was just discussing in terms of the step-down occupancy. And the Couva step-down facility was actually activated this afternoon. We have 10 beds with full resources, and of those, they are already filled. In closing, I'd like to remind the population to not become prematurely comfortable with the decline that they may have seen, or very small decline in terms of the overall hospital occupancy. This decline is due to additional beds that are being added. In other words, the Ministry of Health continues to increase on the supply side, but our resources continue to be strained. We are moving doctors, nurses, and ventilators between hospitals based on demands. The population needs to be reminded, and as a country, we need to be reminded that the only way to reduce the supply side of this equation and to really win this war against COVID-19 would be to continue practicing the 3 W's. On behalf of all frontline staff, we would like to remind the population to continue to wear your mask, watch your distance, and wash your hands. Thank you very much for this time this afternoon. I now hand you over to Dr. Trotman.
Honorable Prime Minister, ministers, colleagues, CMO colleagues, members of the listening and viewing public, members of the media, members of the healthcare sector. Today, I'd like to give a clinical overview of that patient that goes into the bed. We have talked before and emphasized by Dr. Pasram that we are seeing a bit of a difference in the demographics of the patients. The patients are a bit younger overall and with less comorbidities, sometimes allowing them the opportunity to fight COVID-19 more effectively. But we are still seeing the elderly population with comorbidities who unfortunately have a higher chance of not doing as well. What we can do clinically for ourselves, particularly for those who are staying home, because the numbers show we have more people at home. Most times, most people at home are in an environment where there is somebody who is actually COVID positive. So you are primary contact and risk of exposure is high. So we are asking that you please remember your 3 W's even while you're at home, and to wear your mask and effectively isolate from each other. It's also important for us to remember, for those who are going out, that we do not do so if we ourselves become ill. Less of us should be moving, because the state of emergency occurs for all citizens of Trinidad and Tobago 24 hours a day. That our movement should really be if it's only essential, and that has been determined by the regulations as to who is essential. It is not business as usual. I have to tell you that we are worried still as the health community, because in moving around, we are still seeing a lot of movement, particularly in the daytime. So think about it. If somebody needs something in the grocery, everyone doesn't have to go. It is for us to understand that the virus moves amongst people and jumps amongst people. So please remember to try to restrict that movement and essential activity only when moving. And when you're at home, to remember to distance yourself and remember your 3 W's. The healthcare professionals are trying hard, but we are getting tired. It is a lot of work to deliver that high level of care. The COVID-19 patient, it is not the same. And you can help us by decreasing the burden in terms of numbers. And you can do so by doing the 3 W's. I want to encourage that when the vaccine is offered to you, that you take the vaccine. And remember that even as you take the vaccine, the 3 W's continue. Members of the public, we will win this fight. Together, we do our 3 W's, and we remember, if we are sick, that we do not go to work. And we also remember that even when we vaccinate, that we continue to stand on those pillars. Thank you.
Thank you very much, Dr. Trotman and CMO Dr. Abdul Richards and Dr. Hines. Members of the national community, I'm sure that many of you would be consulting your calendar and saying that the 23rd is not too far away. And when we started on this response to the increasing numbers of infections and also deaths, we had indicated that the actions that we were taking would be until the 23rd of the month. Today is the 22nd, and then long before the 23rd was approaching, we had to intervene and make additional restrictions, all in the fight against the numbers that were pointing to increased infections. Then, last time, we had to go towards a state of emergency. Excuse me. We are now in a state of emergency, and we are requiring to abide by those. Let me just, for clarity, point out that the simple responses that we are making to a simple understanding of the situation is that close human concentration and human movement, these two conditions, closeness of humans to one another, movements of humans in their spaces among one another, those are the conditions within which the virus that we are affected by propagates. And depending on that closeness, depending on those movements, the success or failure of the virus is what Dr. Hines reports in those numbers and those graphs. So the virus first has to survive among the human population. If it is there at a low level and we are moving around or we are too close to one another, then the virus resurges. And of course, if it continues to resurge without restraint, it overwhelms. That is what we're dealing with. So these, what you commonly call lockdowns at various levels, are meant to slow the spread of the infection, make the environment for propagation of the virus to be difficult for the virus, and that should reflect itself in lower infection levels, which are reported by the population as they show up with clinical expressions before the doctors. And while we're doing that, we also are vaccinating the population. And of course, you understand from Dr. Parasram and his team why vaccination, how it works, and how it is going to affect this fight. Now, whatever we do comes under these two categories: discipline and vaccinate. Under discipline is where you've been called upon to do these simple things of wash hands, wear your mask, and of course, watch your distance. If you are required to do these things, I don't know that you can look to the rest of the population beyond your personal self to wash your hands, unless you're small children under adult control. So let's take the wash your hands out. That is basic hygiene from primary school teaching. Watch your distance. That is discipline. And it didn't say watch your distance when the police is present, or when the prime minister is talking, or when you're out in the road. It actually, now more than ever, is required in many households in the country. Because from the information that we are receiving and from the data that we are tabulating and analyzing, is that a lot of our problem right now, a significant portion, is happening within inter-home connections. So isolation, as is practiced in the institutions, in the hospitals, those persons who are at home and are either known to be COVID positive, have symptoms that indicate that they may be COVID positive and therefore following the instructions, if you don't feel well, if you're sick, you stay home. What goes with that? For your personal attention, where only you can deal with it, is some level of isolation if you are able to, because we do know that in some household environments, isolation is physically almost impossible. But where you do have the opportunity, every single one is important, because this mathematics starts with 1, and 1 doubles to 2, and 2 doubles to 4, and 4 doubles to 8, and 8 doubles to 16, to 32, to 64. That's how it goes. So at that level, at home, try and remember what Dr. Trotman is trying to beg us to do. Be aware, and not sometime, is all the time, because the virus does not take weekends, it doesn't take holidays, and it is not a respecter of persons. All it wants is a human body. And of course, with respect to the discipline of wearing the mask, unless your nose and your mouth are covered by the mask, you are not masked. The mask covering your mouth only, with your nose outside breathing as normal, is virtually useless in your fight and our fight. And a mask below your chin to be pulled up if you see the police car is not being masked. Recently, I had the opportunity, because if I came back from Tobago, I remember passing 7 gentlemen having a line, not too distant because they were fairly close, sitting on a somewhere, and all were masked, but all 7 masks were below chins. Now, if they were accosted by an officer of state in the state of emergency, you just pull it up over the nose. And I presume, as soon as the officer would have gone, for comfort, it comes down. So remember, if your mask is not covering your nose and your mouth, particularly your nose, you are not masked. Having a mask hooked onto your ears and under your chin. And I tell you this because the reports that we are receiving and which we are seeing is that a large number of people are still not masked. They may have a mask on, some don't have it at all, and you wonder if they live here, if they are aware, or if it is that they just don't care or they feel invincible. That sense of invincibility will only surrender to a high mortality report. And if it is that you are excusing yourself from it, understand that you're playing Russian roulette. Maybe I could do this and get away. Chances are I may not get away. And of course, in vaccinating, I say to you what the experts have said: use the vaccines that are available. We have laid a yardstick that our vaccines will be vaccines approved by the WHO. Vaccines were available to us before without WHO approval, and we could have used them. But for all the good reasons given, our policy in this country was and continues to be that we will wait for the product to be certified by persons who we trust, and that trust comes to us from our international specialists. When they put the stamp of approval on it, we say then we'll use it. So it is not for us now to play biologists and to play virologists and to play whatever and say, well, we are into preference now. Well, of course, it's voluntary, so you always have that. But I would like to say the preference that we should have in Trinidad and Tobago, the preference is for WHO or non-WHO vaccines. That's where the country has been. Some of our CARICOM colleagues did in fact use and are using non-WHO approved vaccine. They use that. Our preference as public policy is WHO. So once we have the WHO approval, I am pleased to hear that the last batch that we got from a new source has been accepted and is being utilized, and the minister will tell you a bit more about that in a while. But once we get the WHO approval on products, we expect that they will be utilized on that basis. So what is the government's role in all of this? Because I seem to always want to emphasize the personal role. That's because, first and foremost, we come out and tell you, the government has taken responsibility for this population. You may ask, why is that being mentioned? That's what governments do. There are governments in the world that didn't do that, you know. There are hundreds of millions of people around the world today facing this very virus, where the government has not taken the kind of responsibility that we have taken from day one. And we took it on the basis that what this virus could do is to cost you your life, threaten your livelihood, and it is a medical issue. A medical issue. Because the virus makes you sick. You spread, if you are infected and not under control, you spread a medical condition to other persons, and the end result is the ultimate in our existence, which could be death. That's what it is. And your government has been with you from the beginning. Some things we can prepare for, and we were as prepared as we could where we are, and some things we couldn't prepare for, because as you remember, this started out as the novel coronavirus. The world didn't know anything about it. It came to us as human beings. And for a year and a half now, we have been fighting it in every corner of the world. Hot zones, cold zones, high zones, flat zones. Rich countries, poor countries, we are learning as we go along. We are in a much better position today because we have some vaccines that are working, and we do have some severe challenges with those vaccines in terms of their distribution. But we here in Trinidad and Tobago, we have begun to see an improvement in the availability of vaccines to us. And we have been working very hard to improve that availability, and we anticipate that as we go forward, that the vaccination side of the fight will keep improving and getting better. For each person that we vaccinate, we are one step closer to a position where we want to be. So let us use our vaccines and not end up in a situation like some people have, where vaccines are now being dumped in some areas because they waited too long to have them on their way into arms, and these vaccines expire. They have an expiration date, they have a use-by date. We will make every effort to use every dose that we have within that expiration period, because it has now been very clear that once you get past the expiration date, the product ought not to be used. So we don't want to get there. One of the reasons why we have been able to receive two significant contributions from our CARICOM colleagues is that we at CARICOM, we have been fighting this together in a way. We have the bilateral approaches on the end, but basically CARICOM, we have been communicating. In recent days, I have been in communication with a number of my colleagues, whether it is Guyana, whether it is Bermuda, whether it is St. Vincent. And the offer from St. Vincent had to do with a preference there. And interestingly enough, their preference is for another product which they had used before WHO. We are hoping that they will get all that they need, but suffice it to say that the gift from St. Vincent is well received. We accepted it after it became very clear that they were in danger of ending up with expiration issues. And the last thing we want in the CARICOM is for one dose of that vaccine to be unutilized because of expiration problems. Having said that, in the event that something happens in St. Vincent in the not too distant future or whenever, and we are in a position to reciprocate, I will not hesitate to return to St. Vincent any equivalent that we can afford. But in the meantime, thankfully, the blessing that they are having now after the volcano experience is that they do not have an outbreak, and they are able to get away from vaccine expiry by cooperating with us. Bermuda, being, as I told you at the last sitting when we were here, I told you Bermuda had got a fair attention from the British government, it being a British colony. They have preferences which they could utilize, and therefore they could share with us in a way without threatening their own positions, and they did not hesitate to make some of their doses available to us. So that's where we at. But so far, ladies and gentlemen, we have done pretty well as a country. At the very beginning, at the very first press conference I had, talking to the population about what was coming to us and how we will respond, I did indicate then that this virus will threaten us in a very serious way, and we did have strengths and weaknesses as we are being called upon to deal with the COVID-19 virus. I said to you that two of our strengths were, one, our banking system was strong, that is to support the livelihood side, and of course the life side if you have to pay for things. And two, our health system. We did have in this country a strong banking system, and we did have in this country a strong health sector. I think the average person in Trinidad and Tobago would have been pleasantly surprised at the role that has been played by the health sector, which under normal circumstances, whenever they make news, was usually when something went wrong, but a whole lot of things were going right. But I would say, spectacularly, our professional staff has come to the breach and have distinguished themselves from day one. And once again, as Prime Minister of Trinidad and Tobago, I want to hold out to the population that we ought to count our blessings, that we were able to have within our population the professional response in healthcare delivery that Trinidad and Tobago has had. And that is what the government committed to, and that is where we're at. And that is why, as we got into phase 3, or we were threatened by phase 3, the whole question of our ability to provide that healthcare came to the fore. And the presentations of Dr. Abdul Richards is a feature of our presentation every day to let you know that it is driven by how we can provide that healthcare to those who require it, especially in the hospitals. And of course, relying on you at home and in the street and wherever you are when you are awake, relying on you to do your part while the government and its officers do their part. While we have been doing that, it has not been all plain sailing. Because while some of us stay awake at night into the wee hours of the morning, thinking how we're going to ensure that the numbers go down and that the reports on deaths and family pain is reduced, there are others who have other objectives. I could tell you, the government of Trinidad and Tobago has spent millions of dollars in this. But among the millions that we have spent is in the courthouse. Because some of us, particularly some of our political colleagues, have in fact taken positions to challenge our actions at every turn. Now, that is their job, that is their right if they choose to do it that way. But I just want to let the population know that we have had scores of court matters where virtually every step of the action we have taken under law has been questioned in the court. Thankfully, we have done it right, we've done it well, and we have won every single one of those court challenges. The very last one was a challenge to the use of the actual health ordinance that was prepared and put on the statutes, so that in the event that there is a situation like this, there was lawful provision for the state to intervene, to do what had to be done, whether it was typhoid, whether it is COVID, whatever it is. Once there was a public health emergency like that, we had a law on the book called the Public Health Ordinance. That is the last one that was challenged in toto, because it was disaggregated and challenged in pieces and in parts. And you may be surprised to know how much of his time the chief medical officer had to spend paying attention to affidavits, so that when the challenge comes up in the court, defense is required. And of course, you would have heard about the whole question in the early days about the government hiding information from the public. It didn't matter that it wasn't true, but it was being said then that people were dying in the hospitals. Even before we had our first reported death in Trinidad and Tobago from COVID, some of my colleagues were saying that people were dying in the hospital and we were hiding it, and that was an aspersion on the professionalism and the character of the professional staff that I just told you have been our savior. But that was par for the course. When the first person actually died from COVID, we learned that from the opposition leader, not from the hospital or the family. In fact, the family heard it from a political mouth, and that was improper. And we condemned it, and we continue to condemn the insertion of some people. If you're not going to help us fight this fight, then stand aside for God's sake. Do not get involved so as to make our life more threatened and the lives of the people who are handling it. And I say this today because recently I heard the opposition leader on a political platform saying that the policy of the government is to determine that older people with comorbidity should not be taken care of in the hospital. They should be put aside to die without care because we are now focusing on younger people. Ladies and gentlemen, I find that very painful. I find that very painful to take because it is not true. This government has no such policy. This government has indicated no such policy to our professional staff because the government, as you understand it to be, stops by the hospital door. What goes on inside the hospital with respect to your life and even your death, we leave that to those who have taken the Hippocratic oath. So, notwithstanding what anybody else will try to tell you acting on your behalf, that is not true. Doctors in the hospital in Trinidad and Tobago are under no instruction or direction as to how to act when patients report to them and present clinically. Public policy on these matters are known, but with respect to care of individuals within the institutions, that is not true. So the first, that was about a week ago, that accusation would have cast an aspersion on the professionalism of the very people who we are thanking and praising for the outstanding job that they're doing. But of course, in this era of the big lie, if you can give birth to an argument, especially to those older people who are fearing for their lives, who believe that COVID could be the one to take them to their maker, if you could tell them that the government is saying that they ought not to be, I want to give all our senior citizens the assurance that this government, as we said for our children, we will do everything that is feasible for the government to do and pay what has to be paid as long as we can afford it to ensure that you enjoy every day of the life that you can have, that God has given you. So please ignore that. As if that wasn't bad enough, a few days later, from the political arena again, we are now hearing that doctors in the hospital are being moved around because of political victimization. Now this is now casting an aspersion on the management of the hospital system. People who have been on the job for a year and a half without a break any day, they are now being accused of taking political instructions to determine what goes on, who goes where in the hospital. Ladies and gentlemen, who goes where in the hospital has to remain under the management of the hospital system. I have no idea who these managers are. I might know the people at the top because they report directly to the minister or to the public, as the case might be, but in terms of managing who does what where, nobody has a will or a deed for a hospital bedside anywhere. We are all fighting this fight, and the singular enemy is COVID-19. So today, I want to ask whoever is doing it, stay out of the hospitalization program in Trinidad and Tobago. Your political opportunities will come. That is protected under the Constitution. But trying to create these kinds of loss of trust in the people who are saving our lives is uncalled for, is unnecessary, and we will not stand for it. And for those of you who believe that I should not use this platform to respond, we are dealing with COVID. And if my colleagues in the parliament or in the politics are intervening to derail us and to make our people who are saving us question themselves, this is where we will respond. We will respond from here when we talk to the population. It is uncalled for, it is unnecessary, and we are playing with people's lives. And I'll tell you something else too. If those kinds of arguments that are being fostered now about the behavior of our professional staff, if they are allowed to take root, that politicians could give instructions to our professional staff who have distinguished themselves publicly, when it takes root in this country, when that cancer begins to grow in this country, it will not be able to be prevented from being metastasized. Keep the politics out of the hospital wards. I could tell you, ladies and gentlemen, that we've been making a lot of efforts to get as many vaccines as we could into Trinidad and Tobago. And all our friends, wherever they are located, are working for us. There was a meeting recently where the world was confronted by what is happening. And while the vast majority of people in this country, in this world, live in countries that can be categorized as medium income, low income, poor, extremely poor, the fact of the matter is that now that vaccines are available to the human population, 0.3%, 0.3% of those vaccines have been made available to the poor and low-income countries of the world, while 83% have been consumed by the minority of the rich and wealthy countries. Those are the facts. That human embarrassment and human disgrace has now caused some of these countries to immediately respond by saying that they will respond to that situation. And in the coming weeks, we have had commitments from countries that could make a difference with respect to the availability of vaccines to those of us who are not categorized in the zone of the rich and powerful. And of course, some of the producers themselves are now taking steps to see whether they could enter into contractual arrangements with small countries. One of the difficulties we had in the very beginning was that we tried to approach, before it was tied down as not being available, we had tried to negotiate vaccines on the scale that we needed at the national level, only to be told that those volumes were not really being considered at this time. I hope now that the environment is changing, that those of us who need small volumes, like 1.5 million doses, 2 million doses, 500,000 doses or so, that we do not get that same treatment again. While we may need 1 million doses, we can't use all in the same day or in the same month, and because these things expire, we don't want 1 million doses in our hand right now, and then find out that we can't use them because they're expiring in a week's time or so on, which is what has happened in some instances. I know one of my CARICOM colleagues, when the African distribution was taking place from South Africa, and they looked to the West, one of our CARICOM colleagues got a few tens of, I think 75,000 doses. But the problem there, which was that, hey, you can have it, but it's only good for another 10 or 12 days. So we don't want to be in that situation, but right now, we are beginning to ramp up, and I want to thank those organizers and staff who are actually at the vaccination zones, and I want to join the minister in apologizing to those people who tried to get arrangements made by the booking system, but we are working on that to improve that, and two things will happen there. System-wise, some improvement will come there, and secondly, as we get more vaccines committed to coming to us, we will be freer to use up all that we have. Because it's a two-dose system, with the brands that we're using, we have to use only half of what we have for first dose, holding in hand enough for the second dose. So I'll leave that to the minister and the doctors to explain. I would like to ask the minister now to give us a few comments on the whole question of how that program is going and how we are doing with respect to ensuring that healthcare is available to those people who require healthcare, because that is the yardstick that's going to measure our success or failure.
Thank you very much, Prime Minister, colleagues, Minister Hines, Minister Young, Minister de Norberger, Chief Medical Officer, Dr. Richards, Dr. Trotman, Dr. Hines, ladies and gentlemen of the media, members of the public, wherever you are. Let me bring you up to date on the National Vaccination Program before I go any further. First of all, I would like to thank, again, the governments and peoples of both Bermuda and St. Vincent for their very generous gifts. And I will explain how we intend to use those gifts. The overall objective as we stand now, given our current vaccine availability, is to vaccinate 134,000 persons with both doses of either the AstraZeneca or Sinopharm vaccine by August 31st. So that's the overall objective, which is going to be just under 10% of the population. Now, that is a pretty good place to be by August. How do we intend to do that? One, we have already first dosed 60,000 persons with the AstraZeneca vaccine. So that's 60,000. We have in reserve 60,000 vaccines for them. That second dose vaccination program starts on around June the 6th or June the 7th, 2 months after the start of April the 6th, because you have to give your second dose of AstraZeneca 8 to 12 weeks after your first dose, okay? So we would have started the Tuesday after Easter. I got my first shot then. We start the second dose on around the 6th of April. So that's 60,000 persons. The Sinopharm gift of 100,000 persons, again, it's a 2-dose vaccine. We'll be vaccinating 50,000 persons in this first round, which started yesterday. At the close of play yesterday, if I could use a cricket term, we would have vaccinated 1,936 persons, which is a phenomenal response. Our estimate was 1,005. So we vaccinated 1,936, and I'll give you the breakdown. Southwest Regional Health Authority, 556. Northwest, 255. North Central, 695. Eastern, 310. And Tobago, 120. It is our intention to use about 20 to 25 vaccination days maximum to get out these 50,000 shots, because the interval for second shot of Sinopharm, unlike AstraZeneca, is 3 to 4 weeks. So you are seeing how we are starting to roll towards the objective of 134,000 people fully vaccinated by August. I want to make a plea right now in talking with Ms. Carolyn Ruiz, president of the Homes for the Aged. We have put aside 1,000 doses of Sinopharm vaccines for the exclusive use of both staff and patients in these long-stay homes. We have already started the vaccination program by vaccinating, first of all, the staff that goes into these facilities, using them as a firewall so that they don't take the virus into the homes. That process has started under the directorship of Dr. Doon in conjunction with Ms. Ruiz. However, in talking to Ms. Ruiz up to this morning, I have her permission to use her name and her permission to make a plea to the guardians of those elderly persons who cannot give consent, that we need informed written consent to vaccinate those individuals. She has indicated that so far that has been going slowly. We cannot vaccinate these individuals if for mental or other reasons they cannot give informed consent. And we have a very litigious society. So both myself and Ms. Ruiz are sending out a call to the guardians and children of these persons, we don't want them to contract COVID. So please give the consent. I think consent forms have been done and given out to all homes. Work with the homes so we could vaccinate all our cherished elderly. These are people who have paid their debt to who have worked for society, retirees, great-grandmothers, great-grandfathers. They deserve to be vaccinated, but we need permission. So 1,000 doses has been set aside for that. The question is going to be asked, and I will answer it now, how are we using the gifts from Bermuda and St. Vincent? So from St. Vincent, we are getting, or have gotten, 16,000 doses, and we expect 8,000 doses from Bermuda. That gives us a total of 24,000 doses of AstraZeneca vaccines. You may recall, we started to use the first tranche of AstraZeneca vaccines in phase 2 to go into ministries and so on. So we have allocated those 24,000 doses to the following ministries: National Security, Works and Transport, Education, Energy, Local Government, Finance, Attorney General and Legal Affairs, Social Development and Family Services, including street dwellers, they will get theirs there, public utilities and healthcare workers. We have chosen these major frontline ministries because you want your electricity grid to be up, you want water to be up, you want works and transport to be up, you want prison service to be up, you want police to be up. So this vaccination program starts on Monday, 24th of May. We have dedicated one site to it, that is the Tacarigua Racket Center. And each ministry, depending on the numbers, have been allocated specific days. So we ask the employees who have been chosen by your permanent secretaries, your heads of departments, to come on those days and accept the vaccines. If the vaccine rollout, if we don't get the numbers we expect, then we will reallocate them to other ministries. But I'm sure we could expect a lot of good turnout. So that is how we intend to meet of our objective of vaccinating 134,000 persons fully vaccinated by the end of August. I'll go through the figures again. 60,000 already have their first shot of AstraZeneca. Their second shot starts around July the 6th. 50,000 with both shots of Sinopharm, that has already begun, and 24,000 with both shots of AstraZeneca, which starts on Monday for selected frontline ministries to keep their operations up and running. I just want to close by echoing what the Prime Minister has said about vaccine preference. My own words are this: the best vaccine for you is any WHO-approved vaccine that is in front of you at that time. Take it. It will save your life, your father's life, your mother's life. So that is where we are, Honorable Prime Minister, with our vaccine drive. Let me just close by saying we have taken note of the issues facing persons trying to make appointments. We are testing an IT system this weekend. We hope to have it in place on Monday so persons can make appointments easier online. We do apologize. It's a work in progress. We are using the same IT platform. We reached out in the Ministry of Public Administration and Digital Transformation. We are adapting what is being used at the Solicitor General's office, which is working well, and we'll be rolling that out next week. Thank you very much, Prime Minister.
Thank you very much, Minister. Let me just clarify one point, which I suspect would be exercising some minds. What the Minister has said is in the context of the vaccines that we have available to us now. It is not that we have put a mile marker that we only want to do 100,000 by a certain date. That date and those numbers are in the context of the vaccines that we now have or that are on their way to us. between now and August, we expect to get more vaccines from other avenues. Once that comes to pass, we will add that to what the minister has said. Because if the big countries do what they're saying they are going to do, which is to put a lot more vaccines immediately into the COVAX mechanism. In fact, that decision is being mulled on right now as to whether to go into the COVAX system and have it reallocated by the COVAX system, or whether to go bilaterally and give it to countries one-on-one. As soon as that decision is made and those vaccines begin to flow, as we expect they should and would, we expect that between now and August, we could increase the amount of vaccine doses available. And as they become available, we then add them to that number that the minister has called out there. So I don't want you to go away thinking that we are only aiming to do 10% of the population. Actually, our target is 60 to 70% of the population. And that is restrained only by the unavailability of the vaccines. But we anticipate that that availability issue will recede as more vaccines either come into commercial availability or by the distribution from those who have been holding on to them by contracts or in warehouses. So I just wanted to make that clear. It's now, we have a 20-minute question period, and I would give the opportunity to our media guests to identify yourselves and put your questions to any of us who are here.
Prime Minister Alicia Boucher from TV6. I wanted to ask, because I would have noticed that President Biden said that 60 million of the 80 million vaccines, they're AstraZeneca vaccines that would have been produced in the United States. You can correct me if I'm wrong, but I also know that only 2 sites were WHO approved, which is SK Bio and the site in India. So I was wondering, how does government plan to get around that aspect? Because I know that in terms of the other 20 million, I'm not sure what it's going to be comprised of, but if they're going through COVAX, you know, then...
I think the CMO would be in the best position to answer that.
Yeah, so there are 3 sites for AstraZeneca that are approved by WHO at this point. You started with the Serum Institute of India, together with, as you said, SK Bio of South Korea. What they added thereafter, we would have received our second tranche from a plant in Italy. And that plant, of course, would have been manufacturing in Europe and then added to the COVAX facility. Generally speaking, as you add plants, WHO takes a plant onto the COVAX facility. Once it goes into COVAX as a mechanism, they have to approve that plant. They look to approve that plant prior by WHO. So the assessment will be done at whichever plant is producing the AstraZeneca before COVAX accepts. That plant will be evaluated by WHO. And of course, if they are not given the green light, I don't think COVAX will accept it. But that's generally the process that it takes place.
So if the discussions then are happening bilaterally, outside of the COVAX facility, then what do we do?
Yeah, so I mean, as Prime Minister said, the policy of the government is WHO approved vaccines, which includes the manufacturing site. So let us see what happens in the coming weeks.
Good afternoon, everyone.
I just want to say, if this COVID becomes so threatening to the human population, as you have seen already, some countries have decided not to wait on that approval and this protection it provides, but to use a vaccine as a mechanism of defense whenever it's available. And that brings me to the question of the Cuban vaccines, because that comes up in national conversation from time to time. Cuba, as you know, has a close relationship with us in medical care, and we are anxiously awaiting a Cuban vaccine to have an evaluation by WHO where we can get some access to it. We would love to be able to have access to the Cuban vaccine, which you would hear on the radio sometimes people say Cuba has had approval. That is not correct. While Cuba is testing 2 or 3 potential candidates, none of them have so far gone through the WHO approval process and has come out of it yet. So we are just waiting on that, and we're hoping that happens. That will be very good news for us. And also, there's another discussion that is taking place, and they seem to be taking so long, whether in fact the patent issue will be settled so that countries that have the manufacturing ability to add vaccines can do so without breach of patent. But what we're having is the world being its normal self, where people are protecting their profits. And that is a fight where lives and profits are locked together. We can't play in that game because we don't have the manufacturing ability, and two, we don't have the political and other sway. But if a decision is made to allow the patent issue not to be an impediment in the supply chain, then that will increase the amount of vaccine. I saw Pfizer saying today or yesterday that they intend to make by next year 2 billion doses available to add to the world's demand. And of course, Pfizer operates in a commercial environment, and of course, we'll have to sell it. When it comes to that, when that production begins to become available, we too expect to be able to buy it off the shelf. But a product that is in such high demand even before it is produced, the line to get to what comes off the chain is one that you have some sharp elbows are needed there, or some good friends.
Good afternoon, everyone. Kimberly D'Souza from TPT News. I have a question for Minister Dialsingh. Minister, we have some of our listeners and our viewers, they're asking us when the other phases of the vaccines are going to roll out, because we have some very eager people in the population who want to be vaccinated, but they're still waiting, to see when that phase will roll out. Also, Minister, can you tell us or give us an update on how many vaccines from the COVAX facility are still remaining?
Sure. Thank you. So thank you for the question, Kimberly. So your question is predicated on the fact that there's a high degree of vaccine confidence in the country. So let's start with that, and that is good. The next phase will be phase 3, which depends, as the Prime Minister said, on the availability of commercial quantities of vaccines. That is when we roll it out to the general public. That is dependent on getting vaccines in commercial quantities, for which the Ministry of Health is working very hard with behind the scenes. So that is where we are with phase 3. How many vaccines are remaining from the COVAX facility? So the first tranche of COVAX vaccines came in on March the 30th. That was 33,600. They have all been used, right? We got in 40,000 AstraZeneca from SII. We used some of that to vaccinate 60,000 persons. So we have now to hold back what is coming in, what came in, on May the 10th, 33,600. That has been held in reserve, plus the remainder from the SSI, SII, gift from India to vaccinate those 60,000 people with their second shots, right? So there were 3 tranches of AstraZeneca vaccine, what we call COVAX 1, all used up. AstraZeneca donation from India, some used to vaccinate 60,000 persons, some being held in reserve, and COVAX 2 being held totally in reserve to vaccinate 60,000 persons with their second shot. Okay?
One more question.
Sure.
So I'm not sure if you will know the expiration date for the vaccines that were given to us from Bermuda, if you have that expiration date.
Bermuda is expiring in June, is it? June 30th. Yeah.
And the ones that we have in reserve from the second tranche of COVAX?
The second ones expire in August 31, right? So that's why the gift that we got, we have to start to use it from Monday. And that's why I'm urging all the employees of TNTech, WASA, prisons, fire, police to use out those vaccines. Because they got overage. They got overage. Mm-hmm. No, it's this and this. Yeah, okay, Kimberly, you're welcome.
Minister Dialsingh spoke about a 10% target for vaccinating the population by August. You said the ideal target is 60 to 70%. I'm sure members of the public are watching and trying to figure out, is there a certain percentage that we'll see regulations roll back, and there'll be like a sort of target percentage that we'll see some degree of normalcy again?
Sorry. Please.
Prime Minister, Minister Dial Singh, the health minister, said he's aiming to get 10% of the population vaccinated by August. And you said the ideal target is 60 to 70%. I'm sure the members of the public watching and hoping there's a target percentage that we might see some degree of normalcy again. Is there any certain percentage you have in mind that, will conjure or mean a certain amount of rollback from the regulations?
I don't want to go down that road because that is just going to create more speculation to create speculation. We will be guided by the condition in the country. And having said that, thanks for bringing this to the point. The regulations, the public health regulations, which they would be extended to the 4th of July. Right? That will allow us to deal with the question of quarantine and mask wearing and so on. And of course, we're in a state of emergency. That will go until it is when we go to the Parliament tomorrow. We will take the 90 days that the law allows, but it doesn't mean that we are going to be in this situation for 90 days. We will revoke it as soon as that is the prudent action to take. Whether it is 1 month after, 6 weeks after, or whatever time, we'll want to come out of it as quickly as possible. But we'll have the legal ability to go for 90 days. And so all of that, both the state of emergency and the public health regulations, will be determined by what the condition is in the country at any day. So if we get a good response in the next fortnight, of course, as I told you when I started this afternoon, May 23rd was what we were looking at as a 21-day period after we intervened a few weeks ago. We certainly can't now come out and say the date has been reached. The date has been reached, but the expected condition has not been attained. And in fact, it has worsened. So we are now looking further down the road. So what we're really looking at here now, as of today, I can tell you, we're looking at 4th of July. That's in place now for the public health regulations. And of course, the 90 days for the conditions of the state of emergency. So we are managing it based on the kinds of response we're getting. We get a good response, as we said early on. The more disciplined we are on this, the more successful we are in managing our infection levels, the quicker we come out of this. So when you see anybody doing something that is not helpful, what in effect that something that they're doing is that is not helpful is keeping us or giving us the opportunity to have to stay longer in this situation. On the other hand, if you see them doing the things that we are asking to be done, then you know that, well, we are doing things to get out of it as quickly as possible. And we do want to come out of it as quickly as possible.
To identify myself, Joshua Simongo from Guardian Media. There have been seemingly increases in the number of reports of evictions from apartments and stuff, particularly. I know there are complaints from the migrant population. Are you aware of a supposed increase, and will there be any interventions? Are you perhaps asking will you seek a freeze of evictions?
The government does not legally control those landlord arrangements. What we are asking for is empathy. And for people who are doing that, I just want today to say to you, think of all your family members, all, and ask yourself if there's anybody in your family in another country somewhere who is in that situation, and how do you feel about them being treated like that? This pandemic is calling for a human response, not just a government. There's a limit to what the government can do. Whether this is in the bank, because the bank is owned by the shareholders. The law covers some aspects of banking. The law doesn't tell you to tell the bank who to give a loan to or who not to give it to on what condition. Certain conditions are there under law, of course. But this situation, there's a human response. And the landlords, I hope, understand that they too are targets of this virus. And we are all fighting it together. When we did ask for a 3-week forbearance, certainly we can't ask landlords to provide housing for people for free forever. But this, let us say this is an intervention that we are hoping is a short one. And we just, where the government can act, the government will act. But there are some things that the government cannot be expected to do. And some things by the logistical action alone. Like, for example, you can't expect the government to put a policeman by every door to ensure that there's isolation inside the house, because he will have no jurisdiction once the door is closed. So there are limits to what the state's machinery can do. Because inside the house, the biggest problem you might have is wearing the mask in front of the person that you're offering something to, or that you're lying in a bed with. You might be safer lying on the floor away from the person who is sick, because you're trying to save your life. So these are things that are not governmental things, except that we appeal to the good sense of the human being. 1, try to be humane. 2, try to empathize with other people's conditions. And 3, remember, as the Calypsonians say, the thing ain't care.
Okay, let me ask the question first. Well, directed at you, so November the Newsday. We have been a week into this state of emergency. Could you give us a breakdown as to the effectiveness of it so far, in terms of the numbers? Okay, we're here at the start when we went through numbers. So we did show that around the 2-week or so period after the first big-ish intervention, which was April 29th, we started to see the beginnings of some smaller numbers than projected. So that graph that we had shown, I wonder if we could pull the graph back up. The graph that we had shown started to show a fall away from that projected trajectory about 2 weeks after the bigger interventions. Now, a week post the SOE announcement, you don't have enough time. Go forward. Oh, wait, I have it. Thank you. You don't have enough time just yet to make an assessment on whether that very recent intervention would have been effective or not. It usually takes about 2 weeks for an intervention to begin to show any sort of effect. And we did see that with this particular graph, where the biggest of the interventions, where we started to close retail, etc., and reduce human mixing, seems to be having a trend in the right direction towards slowing ever so slightly, but that only began to be seen 2 weeks after that intervention. A week after the SOE, you won't yet see anything that you can look at on a graph and say, this is effective. What we need to do, however, is we can look at the effectiveness of people's behavior change while we wait for the numbers to show up. So let's look on the roads, let's look in the offices, let's look at the interactions of people and see if effectively we have begun to change behavior in a way that will actually apply the brakes to the spread of the virus. That's probably where we best look for effectiveness at this point in time, and the more effective we are doing that now, is the bigger the effect we will see on the numbers further down.
I have that question to ask this question. On Wednesday or Thursday, I believe it was, the Attorney General was on Twitter and he said that where the SOE would last up until we see 15 positive cases thereabout per day for a 2-week period. And, based on the numbers, could you give us an estimation as to when we may reach at that level?
Okay, so first of all, the statement that is being quoted from the AG is not what the AG said. So that, I think we need to revisit that particular recording. The conversation that was being had was that we were speaking about the change in trend of rolling averages, and that at the point when we were at 15 and moving upwards, we were sounding the alarm that we're going in the wrong direction, and that going in the opposite direction with smaller and smaller rolling averages is where we need to go. Now, as the Prime Minister also just said, we don't have a specific number that we say, okay, when we get to this number, we're going to change things. You're looking at the entire condition of the epidemic, the population, what's going on in the hospitals, what's going on with the ill people. A lot of things need to be taken into consideration before you can make a decision on whether you change what you're doing or not. The last thing you want to do is to make a change prematurely and then reverse the effects that you're seeing because you're seeing the effects. And one of the good examples is you don't jump out of a helicopter or a plane with a parachute and then go, all right, slowing down here, parachute working, let me close it. That's not the best idea. Similarly, with public health interventions, one of the things that we see globally is that sometimes we tend to want to eliminate the public health intervention before we've eliminated the problem. And you see that with other international responses to other infectious diseases. So we definitely don't want to do that in this case because history has shown that there's a tendency to do that and ends badly. So we are going to maintain all of the necessary precautions until we see that the trend across the epidemic is moving in the right direction.
Thank you very much. Alicia, had a question? Yeah. That's the last question, right?
I have two questions. One
Come
for...
again for the last question.
Okay, so my question to you is whether or not government has at this time put forward a proposal to Cuba and in anticipation for possible WHO approval of their vaccine, or whether government has the intention to do that. And that's a question for you, but I do have a question for Minister Dialsing.
I'll answer that. The relationship with Cuba, it is common knowledge that Trinidad and Tobago has a very close relationship. And in fact, we have been out front as an advocate for Cuba with respect to its diplomatic situation. So we have no difficulty in saying to the population that in the event that Cuba's vaccine becomes approved and its production is available, that Trinidad and Tobago, we expect to be there to use it. We want to focus on what is available and also try to get the population to focus on what we can do. You see, if we focus on the vaccine that might come from Cuba, while not focusing on the mass that is below your nose, because even when we vaccinate the population, we will be required to keep doing certain things that some people are not doing now. So let's end on that note, and I want to give Dr. Trotman the last word, to speak to the people who are fighting COVID at home, in the home environment, because those people are the ones, one, who are under a lot of pressure now in managing it, or two, spreading it without knowing. So speak to the persons at home who might, we have told you early on, if you're sick, stay home. So we know that there are people at home who could end up being COVID positive. Acknowledge that and living there with the rest of the family. Those are the people I'd like you to speak to now, Dr. Jordan.
Thank you, Honorable Prime Minister. It is indeed a fact.
Is the mic on?
Thank you, Honorable Prime Minister. It is indeed a fact that we have a lot more people at home. We have response systems for you, even while you are at home. We have certain measures that we use to monitor you while you are at home. And we have responses to evaluate you if you have an acute situation at home. But while at home, and I want to make this point that I actually forgot, is that while at home, if you are waiting for a test, you don't have that test result, but there's a high suspicion that you could have the disease, it is important for you to act as if you have it. Do not go wandering around and say, well, I'm waiting for my swab, I'm not sure if it's positive, and going to the grocery. No. Act like you have it. And if you happen to be somebody who has the disease and think, I'm just going down to get something, you're breaking the basic tenement on which we stand. If you have it and we've deemed that you can stay home, stay home. If you have a swab result that is pending, assume it's positive. and act like somebody who is positive, do your 3 W's. Wash your hands, wear your distance, and wash your hands, wear your mask, and watch your distance. And also, your utensils that you share. It's not for me and for you. Those are yours. You have to be in a separate bathroom. You have to be more stringent than ever because you are being managed at home. Remember, there may be still people in your home who are not infected, and you could keep it like that if you do the proper isolation measures at home. You will help us in the system. We are seeing a lot more of you infecting each other at home. You can put the brakes on that. 3 W's at home. If you are positive and you are with your family members, separate yourselves. And if you are waiting a swab, you don't know the result, please assume that it is positive. Let's do this together as a nation. Every single person counts, every single one. So if somebody after today, one more person, starts doing the right thing, that's a victory, and I'm happy. Make us happy. Then there are lots of you who are making us happy. More can do it. Thank you very much.
Thank you very much, Dr. Trotman. I want to thank members of the media for the job that you've been doing in staying the course with us and informing the population, because an informed population would be a more disciplined population. So thank you very much, and we look forward to having good news or better news when we meet next week, Saturday. Thank you all very much.